for 2 more minutes. We'll start in the next 1 minute. Thank you so much for joining us. We'll start in the next 1 minute. All right, good afternoon, everyone. Thank you for joining us. My name is Dr. Iseko, and with me is Elvis. Good. Elvis, the main man. My name is Iseko. Reaching you live from Cardiocare. Today is a very, very interesting one. Straight from the cath lab, straight from the oven. So I expect you to have a lovely time. It will be a little technical, but just hang in there. You will have a great time today. As usual, we have close to 80 people joining us. We'll be talking about pacemakers and devices, and we'll just go through the procedures if you're an expert. After this meeting, you should be able to understand the process, understand how it is done, understand who needs it, and all. So me and Elvis will just be gisting. And if you have any questions, put it in the chat box, and then or in the Q&A, and then we'll answer it shortly. Thank you very much. So I think we'll go straight ahead. We have quite a number of people already with us now. Anybody that is late is late. Too bad. All right, so let's see. All right, so greetings from Cardiocare Hospital. Can you confirm if you can see my slides? Can you confirm if you can see my slides? Yes, can see a thumbs up. Can see a thumbs up. You can also put it in the box so that I can be sure. Okay, fine. Great. So I'll just go ahead. All right. So greetings from Cardiocare Hospital. This is Cardiocare Hospital here in Abuja. We hope to have. I think we've made a dent in reverse medical tourism in cardiovascular medicine. We are very grateful to God for the opportunity, and we thank you all for joining us, for referring your patients, and that's our cath lab there. And so first of all, we're just going to talk about and introduce it. So Elvis, just can you try and introduce a bit while I think about what I'm going to say?
All right, so good everybody. Yeah, so we're talking about the human heart, an artificial device that is meant to make up for what the natural human heart is doing. So for in case of pacemaker, so human heart has an electrical system that helps the body, helps the heart to beat from time to time. So sometimes that electrical system may fail, and it causes the heart to beat too slow. In some cases, too quick, and then in some other cases, it becomes too irregular. In such cases, a device may help to regulate the heartbeat. So there are quite a number of them. Generally, they have this umbrella name, cardiac implanted electronic devices. For short, will be CIEDs. This year was mentioned CIEDs. And they include pacemakers, which is very basic, defibrillators in terms of ICDs or CRTDs. And then we also have CRT devices that will be cardiac resynchronization therapy devices. So there are two types. One is CRTD, the other is a CRTD. So the D there stands for defibrillator.
This is what a CRTD device looks like. A little bit big. Yeah, go ahead, continue.
The D there stands for defibrillator, and then the P stands for pacemaker. So it's either of those two. And also there is a fourth one, which is largely for diagnosis.
Yeah.
For diagnosis.
Yeah.
That's the loop, implantable loop recorder. And that's just a simple device that helps us to record how the heart is beating, You can do that for up to 3. Give us a good data so we know what to do each of them.
All right. So I think we'll just go straight ahead. And like I already said, 4 major types. 4 major types we're looking at is pacemaker, ICD, and CRC. A common recorder is typically for diagnosing unexploded fainting, but pacemaker essentially helps to tell the heart when the heart is beating too slow. ICD prevents sudden cardiac death, and CRT for heart failure. So I'll just go straight to explain it. The pacemaker, which is something like this, as you can see, I don't know if you can see my video. Can you see my video? So I don't know if you can see my video. So the pacemaker, which looks like this, look at the video, quite small. Essentially consists of a pulse generator which houses a battery, all the electronic circuitry, and a lead system. Let's see if they have a lead there. And a lead system. So the leads essentially are small wires that go to the heart. They get implanted into the heart, and then from the heart they now get over here connected to this. So that essentially is what happens in the pacemaker. So look at the example of a lead. I don't know if you can see it on your screen, but that is an example of a lead that we use and we connect it into the device. So pacemaker, lead, we're going to use these terms very much, so you need to understand it. Lead goes into the heart muscle wall, okay, and this goes into the head, and that goes under here. That is how essentially it is done. Yeah, and then we do it regularly here in Cardiocare. So that's essentially what consists of. Now, the good thing about these devices is that essentially they sense and pace. Elvis, what do you think? What is sensing?
Okay, so sensing is being able to identify something.
Yeah.
So we said the heart has its own natural motion system, electrical system that helps the heart to beat from time to time. So this is an artificial device. The idea is it needs to be able to make judgment. So there is no natural heartbeat, then I need to beat. So if it's not able to sense that the heart is beating on its own or it's not beating on its own, it might not make a proper judgment. So sensing is just a function that helps the device to be able to detect when the heart is beating naturally, and then based on that, it will now act as, depending on how we set it, it will respond to that.
Okay, so essentially, one is reading what's happening in the heart, another one is telling the heart what to do. So sensing is reading what's happening in the heart, sensing the intrinsic rhythm, and then based on what the intrinsic rhythm is doing, it is now giving the heart information to, all right, beat now, since you're beating too slow, beat. Okay. Now for the other CIEDs, like the CRTD or the ICD, they also have another thing on their leads. So if you look at this lead, I don't know if you can see it very well, it has a shiny thing here called a coil, or a shocking coil. And in addition, it can also deliver a shock around the heart, so to the heart. So when the heart has a deadly rhythm arrhythmia like VC, Victor, the coil, the keys can deliver a shock to the heart. That's very important in all of this. Now, like we said, the lead and the pulse generator, which contains the battery. Sometimes we just call this battery, but essentially it's actually a pulse generator. Okay, so we normally have a way of describing when we are pacing. Elvis, can you help explain this?
So there's something called the NBG, the combination of the NASP and the PPEG. So it's a universal code that is used worldwide to identify how we want to offer therapy, for instance. So the first letter, they are actually in alphabets. The first letter is tells us where we want to pace. Now, so sometimes you hear us say D, 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 B, I, A. A stands in general for atrium, D for ventricle. Then the D is dual. Dual meaning both atrium and the ventricle.
Exactly.
So that cuts across all. And so, but the first letter, so I'm usually coming at least three letters. At least 3 letters. If we up to 5, they are majorly 3 most of them. Sometimes 4. So, but the first one is telling us, okay, where do you want to pace? So if you say you want to pace you want to pace both in the atrium and the ventricle, that means you want a D.
Exactly.
If you say you want to pace only the ventricle, that means you want a V. You want to pace only the atrium, that means you want an A. So, and this is very easy to remember because the device is essentially meant to pace. So that's its first duty.
Yeah.
So just take it like that. First thing to do is want to pace. So the first letter tells us where each chamber you want to pace. And we go to the second letter that talks about the sensing. Remember, we talked about sense. Where do you want to sense? Do you want to sense the atrium? Do you want to sense the ventricle? Or do you want to sense the both of them?
Or do you want to don't want to send anything at all?
Sense it.
So sometimes you just want to pace. You don't care what the heart rhythm is. Just continue pacing. I don't care what they are saying. You just continue and do what you are doing. So that is in terms of sensing. So
Yes.
in that case, that will be 0. So it will be DOO. That is, you are pacing without taking any sensing activity from it. Okay.
And there are instances where those are actually, particularly in surgery with patients who have any of these devices.
Yeah.
They're using that. So second line was to sense. So it wants to sense whether there's a P wave or that's in the atrium. It also wants to sense whether there's a QRS in the ventricle. This is important because if there's a P wave, you don't expect the device to pace. The heart has already done its job.
Yeah.
If there's a QRS, you don't expect it to pace as well. The heart has already done its job. So, but when there is no P wave, and then you can see that there's no P wave within a given time frame, that there's no P wave, then the device is mandated to pace the heart. So you can see the function, how the sensing is giving it data it will use to deliver therapy. The third one is, which I've just tried to explain, is how it responds to sensing.
Yeah.
So remember, the first one is basic.
Yeah.
Second one is sensing.
Yeah.
Now the third one is how does it respond?
After it senses, if it senses it's something, what will it do next? Yeah.
So, this is a device. What next? So if I sense, what do I do? If I don't sense, what do I do? That's the third one. So typically, when it senses, so let's go with an acronym, DVVI. That's very basic. VVI. Meaning that I want to place in the ventricle, the first V. The second V, you want to sense in the ventricle.
Yeah.
Then the third letter, which is an I, in this case means inhibit. Meaning that, all right, if you see something in the ventricle, do not carry on with your first objective, which is to pace.
Yeah.
So we vote basic. If you do not see, then go ahead and pace.
Okay.
So it's like yes or no. Is it there? It's not there. Do like this. It's there. Don't do like that. So if it's there, if there's QRS, don't pace. There's no QRS, pace.
Okay, so essentially what we have said so far, for those just joining this Cardiocare Hospital, we're talking about pacemakers and cardiac implantable electronic devices, CIEDs. We've said first that consists of a device which we call the pulse generator that has the battery and all the circuitry, and a lead which is connected into the heart, and we showed that connected to the heart, and from the heart it is connected into the battery and the device. We now see that after doing all of this, sometimes we need to program it, and we have a universal way of coding how we are programming it. Number one, we need to know where it is placing, whether it is placing atrial and ventricle, and that is the first data. So when you see a pacemaker, you can hear it is TDT. T means it is placing both atrium and ventricle. When you hear the second D, means it is actually sensing. So it will sense what is happening in atrium and ventricle. And when you hear the third letter, it will tell you whether, if it senses something, should it trigger the pacemaker, should it inhibit it, should it do both, depending on what's on your setting, or should it do nothing at all. So sometimes that people going for surgeries, we don't want the device to be sensing diatemy or a knife and assume that that's a heartbeat, because if it assumes it's a heartbeat, the device will sit down and say, since the heart is beating, I don't need to work. In that case, the patient will pass on. So in that kind of case, we typically tell the device, don't bother about sensing, just pace continuously. So in that case, if you are pacing continuously, ventricle V, and you are not sensing, that is O, and since there's nothing is going to be sensed, there's no response, that will be O, so that will be VOO. So typically when you are in an emergency situation and we put in a pacemaker temporary, typically we go to VOO. And then the fourth and fifth letter now comes where there's rate response or all of that. So I will not go into that. One of these days, if you can come around and we have time and I'm in a good mood, we can teach you pacemaker detail on how to do that. So the indications, why do we now give patients a pacemaker? One, does your patient need a pacemaker? So we say that a patient will need a pacemaker typically when we'll talk about when you need a pacemaker, when we need an ICD, and when we need a CRT. This is very, very important for the practice so that your patients get the best. We know that, yes, some of these things are important and could have some cost, but however, we are very, very, it's very, very important to us that Nigerian patients get the best healthcare that they could have gotten everywhere in the world here at Cardiocare. So you need to know what patients will benefit from what. When you have a patient with a very slow heart rate is low, less than 60, less than 50. The first thing is that are they symptomatic? So once a patient has a slow heart rate and is symptomatic, meaning they're having dizziness, they're having lightheadedness, they're falling, more often than not, they will need a pacemaker. Now, that is especially with the sinus. Now, the second reason why you have a slow heart rate and you now need to put a pacemaker, whether there's a sinus node dysfunction or a high-grade heavy block, either a second degree, a type 2 second degree heavy block, or a complete heart block. Any of those things will typically warrant a pacemaker to be inserted. Can you talk us through the other reasons why?
The other reasons would be persistent sinus bradycardia.
Yeah.
In such, and then that's where symptoms, we mentioned that symptoms, because some persons might be bradycardic, but they don't have symptoms. In this case, it's persistent and the person is also symptomatic. That person, as a result, that's like sinus node dysfunction. The person requires a pacemaker. From tropic incompetence has to do, normally as we do our day-to-day activity, the heart rate is not a stable, it's not a stable number. Yeah. It doesn't stay one place, it doesn't stay 50, 60, money to 90. It moves up and down.
Where you're angry, you should move. Where you're broke, you should move. If they just tell you that they've posted 2 billion to your account, you should move. Exactly. So, however, in some people, it does not move, it's incompetent. That ability to change his rate is incompetent. So, typically, we test that.
So, you want to, for instance, imagine you're climbing the stairs or you're about running, and then heart rate is not increasing. That person will like it. Exactly. Because the body is requiring a lot of blood to flow around, but the body is not able to keep up because the heart rate is not responding. So, such a person will require a pacemaker to help the heart to keep up with the activity. And then sinus arrest, that's where there is no P wave, you can't see anything. So such a person also, these are all elements of sinus.
So we remember that when we were doing the ECG, said, and if you don't have to do that ECG, just go to our page, webinars, Cardiocare.ng webinars. You will see one of our webinars where we taught on ECG. Or go to our YouTube page, you will see that. I promise you, you'll be able to read it. We know that almost everything comes from the right atrium, right? When the sinus node gives. Sinus node gives out the first one, goes to the AV node, and it goes to the rest of the heart. Okay, fine. In some cases now, we have the problem at the AV node, the junction between the upstairs, the atrial, and the downstairs ventricle. In some problem, the origin gunpoint is the problem of the problem. That's the sinus node. That will have a sinus arrest, which is not doing anything at all. Or sometimes it is having a dysfunction, sometimes going too fast and going too slow because it's unable to regulate itself with all the input that it has. That is a problem that we could have that could cause us to need. So anytime you have documented symptomatic bradycardia, anybody that has symptoms with bradycardia, they need to have a pacemaker. Now, sometimes their bradycardia is caused by a medical condition or by drugs that are used to treat something else, and you cannot stop that drug. In that case, you need to put a pacemaker in. So if they're taking a drug for something else that you cannot stop, and that drug is causing a slow heart rate, now you see how to put a pacemaker. And then on top of the incompetence that we talked about, meaning that the heart is not responsive to where it's supposed to move. And then heart rates less than 40 without any symptoms sometimes have been linked to putting in a pacemaker. So you don't want to wait till they have symptoms because that first symptom could be fatal. So anybody with heart rate less than 40, there's a class 2A intubation. And if you have unexplained syncope, people fainting and you cannot, in the presence of sinus node dysfunction, So you may not be able to do this except you do an EP study, and then you'll be able to do that. Then intermittent bradycardia. I'll move a little bit fast. 3rd-degree heart block, carotid sinus syndrome, all of those. So in summary, when you use a pacemaker, number 1, when there is a 2nd-degree or 3rd-degree AV block. Okay. Number 2, when there's a potential AV block sometimes. Number 3, when you have sinus bradycardia, the heart rate is very slow, and the patient is symptomatic, severely symptomatic, you should consider that. And if the patient has heart failure, needed a pacemaker, in that case, we will now go for a CRT. So with pacemakers, we typically use a dual chamber pacemaker. A dual chamber pacemaker simply means that it is pacing both the atria and the ventricle. Anybody that has a problem is pacing and or sensing. Anybody that has a problem with the AV node, so we say SA node, go to AV node, go to ventricle. So just look at it like this. The connection between the upstairs and the downstairs, let's call it the staircase, has a problem. Whenever that has a problem, you need to be able to get a lead into the atrium upstairs and into the downstairs. So it can sense from the atrium and then transmit the impulse in that way. Okay, so that's very important that we have to do. In some cases, single chamber pacemakers are used. Now, sometimes I see a lot of people being put with single chamber pacemakers. Most of the time, it's not the correct thing to do, except in certain situations. Okay, so Elvis, in what situations perhaps you do this? Is a single chamber pacemaker, by the way, very small, very easy to put. Yes, it's so.
So there are some situations where we have to do a single chamber device according to the guidelines.
Yeah.
And most of those situations are situations where the atrium is already what's the word to use? Let's say inconsequential in quotes in terms of contributing to the cardiac output, the volume of the cardiac output. And so situations where you have atrial fibrillation, and then sometimes in atrial flutter, particularly if it's refractory, all the cardiac action is not because at that point the atrium is no longer, there's no atrial.
So the atrium is too fast, the atrium is beating too much, and so there's no point trying to pace something already beating at 200. So in atrial fibrillation, that could be a situation. You now put a ventricular pacemaker. Yeah. Sometimes if there's no AV nodal problem at all, you might just put a single chamber atrial, but this is very rare. More often than not, people tend to put a dual chamber because you never know down the line, person that develops an AV block, and then you now have to come back. So more often than not, the dual chamber is being put. So we don't typically. So people, if you don't have chronic AF, no atrial problems, and you put a single chamber into the ventricle, you are likely, because you will see some improvement initially, the patient will feel fine, but down the line, it's going to cause problems because you're going to have disordered activity. Okay? So let's talk about ICD for a while. ICD. So what about ICD? So ICD essentially for preventing sudden cardiac death, essentially. That's the summary of it. So an ICD, a little bit bigger than the pacemaker, it's not an ICD, but it's something like this. It's almost the same size. It's almost the same size. So we have this. The ICD is just similar, but the most important thing about the ICD is that it's prevention. The ICD is able to do 4 things. It's able to act like a pacemaker, just like normal pacemaker. Since it has, especially if it's dual or single chamber, since it has this, if it needs to pace, it can send places. But first of all, it is sensing arrhythmias and treating arrhythmias. Then it can pace the heart very fast. So if the heart wants to stop and it goes to a beater and it starts beating at 180 or 200 beats per minute, you know the person will start collapsing, right? Because blood flow is not going to the brain. So what can the ICD do? The ICD can go at 250. That is, you think say the craze, and the craze pass. So it will take the heart rate higher above the beta rate and then bring it back down, bring everybody back down to normal. Fine. So anti-tachycardia pacing. Then it can deliver a shock, deliver an electrical impulse. That is either via a low impulse called cardioversion or a high impulse called defibrillation. Okay, so that's what an ICD does. It's like a guardian angel device. We know the Man U player. What now? Remember the Man U player that collapsed on the field and had to have a cardiac Christian Eriksen. Unfortunately, Man U is not doing very well. So, but he had one of these because he survived a cardiac arrest. So Anybody that survives a sudden cardiac arrest needs to have one because so they don't have another one down the line. There's that footballer that had a cardiac arrest and then had a pacemaker, ICD put in, I think from Cameroon or somewhere, one of the African countries. Went back to play football. After some years, he said he does not want the pacemaker, the ICD again. That's disturbing his life and he needs something. So what did he do? He asked that the ICD be removed. He removed it, and a year later, he died. It's very short story, but very sad story. Okay, but very notable case. If you Google it, you will find it. So I can't remember his name, but he had a device, and then he had a cardiac arrest. He was resuscitated, put a device, stayed several years, and he said he doesn't want it again. Of course, his wishes were made, and it was removed. Unfortunately, he succumbed because the things were still coming. Maybe they are not showed up for 2 years, and then the time he showed up, there was nothing. So occasionally, some people call it a guardian angel device. So who are the people that will have put an ICD in? So first of all, remember that there are many studies that support ICDs. Unfortunately, in Nigeria, it doesn't seem we are putting in. We are our and we don't be hearing remote control from village. Something happened, but really, what's happening? There is conclusive proof from all these multiple trials that certain groups of patients will need to have an ICD. So if they had a prior cardiac arrest, syncope, they've had prior MI with their EF less than 35%. Everybody with EF less than 35%, it is incontrovertible that they need an ICD. So we have so many patients with heart failure, ejection fraction less than 35%. We are still managing less than 30%. They are doing fine. One day you call them and they say, well, something. So we have so many patients, either they turn down the ICD, when we call later on after 2 years, 3 years, suddenly they did not wake up or something like that. So it's very important. We can see marked trials, definite trials, SCD heft, and non-ischemic cardiomyopathies too. Also very, very important. So you can see that there's abundant evidence for this practice. Yes, one of the reasons why ICD is not really put is cost. It's not cheap, and in all of these places where these studies were done, ICD was being sponsored by the government. So we hope that one day we'll have such in our country. Okay, so before we go on, just remind you from Cardiocare Hospital, we're talking about ICDs, pacemakers, CRTs. CRTs are cardiac resuscitation therapy devices. We are explaining it. These are devices that we commonly put every other day and that we interrogate and follow up here in Cardiocare in Abuja. And we just thought to explain these things to you so you can explain and you can understand and do better for your patients. Okay, great. At the end of this, you receive your CPD if you register with your email address, 1.5 CME points, as well as you could get some slides. And if you want to add it to the WhatsApp group, you just let us know. Add it to WhatsApp group, you can know about future things. So, what are the indications for ICD? Number one, secondary prevention. Secondary prevention means that something already happened. So, patient that had any cardiac arrest due to VM. We had a patient that had a VT in the hospital. Put an ICD. He came, he's done very well. Done about 2-3 years. I still saw him at the heart failure support group. By the way, we have a heart failure support patient with heart failure. Somebody had failure support group. A year later, he had a ventricular storm. Lots of VT and VF coming in. But thank God the device was there. That device saved him enough to come to the hospital, fighting it, and then still doing very fine for 2-3 years. So the use is without a doubt unmistakable. Anybody that had a cardiac arrest, especially from VT. Okay, so if they've had, these are people that need it. And then we talk about patients in whom primary prevention, they've not had any problem yet, but we think that they are at high risk for a cardiac arrest. Almost all patients with heart failure die from a cardiac arrest from VTVF. So if the EF is less than 35% and after a prior MI, and their MI class 2 or 3, typically will need that. So this is an example. This was a case that happened here in Cardiocare. And as you can see very clearly, we can see, let me see. Okay, good. We can see where the VFib started. And this is at 1:50 a.m. VFib started, VFib generated to generating into VFib, and then the shock is delivered, and the QRS complex comes back to normal. QRS complex. So this was done outside. We recorded it. Luckily, we had a working hemodynamic monitor that was recorded. Fine. Now, this patient this is someone that has survived and now has to have this. Okay, so primary prevention, this dilated cardiomyopathy, EF less than 35%. The way I look at it is simple. Everybody with EF less than 35 to 40%, you should consider them for an ICD, whatever they are listing. Now, there are some people that say treat them for at least 6 weeks and then recheck the EF after 6 weeks. Okay, that's a good idea. That's what should happen actually. But sometimes you also see the case whereby you're waiting for the 6 weeks and something now happens before then. Who do you blame? Okay, so these are things that are still up there, but standard, especially if you had an MI 40 days, typically you have revascularized. You see all that in there, but for other ones, we've talked about all of that. Okay, fine. Who now do we use a CRT for? So let's just explain what the CRT is. So Elvis, can you explain what the CRT is?
So a cardiac CRT, like we said before, is cardiac resynchronization therapy.
Yeah.
So there is something that is quite unique about it, is the resynchronization. Yeah. So the way the heart beats is that the atrium contracts, the ventricle contracts. But then in the ventricle, the left and the right side, they contract at almost the same time. The difference is very, very small, almost the same time. But when you have people who the right is now contracting, maybe it contracts now, then the left will delay after a while before it contracts. So yeah, there's desynchrony between the right ventricle and the left ventricle. So they are not contracting well at the same time. So that will also affect, the cardiac output and then the symptoms of the person. So in such situations, we might need a CRT to help us bring back the synchronization between the right ventricle and the left ventricle. You can also maintain the synchronization between the atrium and the ventricle. So it's just there to pace the heart in such that those conditions are typical people have from the branch, right, left, and all that. We'll go into details. So this device is there to help to pace both the right and the left at almost the same time, such that it will not look like it's the normal way the heart. And that usually, in all things, really help the cardiac output and improve heart failures.
So if you look at this picture, imagine that the people on the right and the left try to push this car are pushing at different times. So what we're trying to do is to make sure that both the right and the left are pushed at the same time, in the same way, at the same with different minimal difference. So we kind of try and put as we put a lead in the RV, put another one in the LV, and try and shorten the time difference. So if you look at your ECG, the QRS duration gives us an idea. Whenever there's a left bundle branch block or the QRS is wide, then we know that there's a dysynchrony. Patients with heart failure that have a dysynchrony don't do well. But the good thing about them is that you can shorten that time between the right and the ventricular activation time by putting in the device called a CRT, and that is what it is. And I've shown you the devices. These are different CRT devices here. Old ones that we removed when we're changing for people. Okay, fantastic. And it can really be life-changing. So the data is clear in terms of improving outcome, length of life, quality of life. In fact, some patients, look at it, they don't have heart failure again. Yeah. Symptomless, edema gone,
they want pillows.
As in sleep, so never started exercise again. Everyday jogging. Can you imagine? Patient with heart failure. So it can truly be life-changing. However, it's for a group of patients. Not everybody qualifies for it that has heart failure. So we look at prolongation of QRS as one of the main things that helps us to define it. Okay. Now, the distance or the worse this dysynchrony, the better the outcome we see. So those that have very long QRS, more than 150, will have better response. Those with left bundle will have better response than those that did not have any serious, maybe if the QRS is narrow, they don't do as well. So not everybody responds fantastically, like we talked about, almost miraculously with the CRT. So about 60-70% of people do have very good response, but those are people that typically have the wider the QRS and better the response. It's very important to note that. So There's a flow chart from ESC. This was 2016, but it's very, very important. So if you have your patient heart failure with EF less than 35, NYK 2 or more, and the QR is more than 130. Now, what do you do? Is it in sinus rhythm or is it AFib? If it is in AFib with QR greater than 130, then 2A, 2B indication, 2AB indication. So either here or there indication for the CRT. However, the sinus rhythm, why do we say this? People with sinus rhythm normally benefit better than people without sinus rhythm. Why? Because you can coordinate not just the two ventricles, you can coordinate both the atria and the two ventricles.
Yes.
So we can have a very good this thing. Good. Now they have a sinus rhythm and the QRS is greater than 150 with left bundle branch block. That is a class 1A indication. Meaning, if you don't offer a patient with this kind of situation, you are probably liable. Okay, so class 1A meaning there's incontrovertible evidence that these patients will benefit and benefit very well from it. So class 1A. Now, we now have those that are in between. Anybody greater than 130 left bundle branch block or greater than 130, they also benefit. And those with non-level branch block greater than 250, they also benefit. So, but then they may not be as strong as the others. You want to add anything? Okay, great. So, and then of course, we also see people that have AF, but they also have indication for pacing. So we may also consider CRTP and if the QRS less than 130, then it goes to ICD. Okay, and of course, but however, anything greater than 130, you should consider very strongly, even if they don't strictly fulfill the criteria. And there's a lot of reasoning behind that. This is from 2016 ESC guideline. I'm not sure there's been much change in this. So, number one, very important, anybody with NYK class 2 and above, EF less than 35%, and then QR greater than 130 should be considered. Now, those with LBB and greater than 150, better. 130 to 149 and non-LBB should be very, very important. That is what it looks like. Okay, so this is a chart to determine what do you put, and this is from NICE. I think we can go forward from here. All right, so this is CRT procedure in situ. If you look carefully at this, let me see. So look carefully at this, we can see this is the RA lead, a lead into the right atrium. Now, this is a lead into the right ventricle. So we have right atrium, right ventricle. Okay. Now you notice that there's this thick area, this thick black area over the lead. If it's a pacemaker, all the whole lead will be thin like this. This thick black area is the shocking coil that allows it to be able to defibrillate. Now, this is a CS catheter. We use this to be able to find where the coronary sinus is and then put the left ventricular lead into the coronary sinus. So, I want to play this. Okay. It's not, I'm not going to highlight. Well, I hope you're that in my other videos. Sorry about that. I hope you're that. So, so we've talked about indications when we use devices. So let's move right again. We've talked about ICDs. We've talked about pacemakers. We've talked about CRTs. We said pacemakers are used when the heart is slow, right? We said ICDs are used when we want to prevent sudden cardiac death, any reason. People that have survived one before, anybody with an ejection fraction, heart failure with ejection fraction less than 35%, especially after some treatment and they're still having that, they need to have an ICD to prevent sudden death. We now talk about a CRT. Now, sometimes we need to go further and help to improve life and quality of life. Obviously, the CRT is the big device. It helps to improve the contractility of the heart and improve function, but it is reserved for those with dysynchrony, those with QRS that are long. Those are what we've talked about. I will show you several studies We showed several studies that that highlight this. We also showed you a picture of this, and we'll show you different devices. So we talk about all of that. Pacemaker, too slow, complete heart block, or symptomatic heart block. Patient is tired, dizziness, blackouts. ICD, surviving cardiac arrest, or at least for cardiac arrest. CRT, uncoordinated beats, wide QRS. Okay, so how do we advance it? So let's go to the how. I don't know if there are any questions so far before we go a little bit deeper. Can see we have over 100 people attending. Thank you for joining us. I can see lots of consultants and senior people here. Thank you for joining us, and of some of our colleagues as well. From Cardiocare Hospital here in Abuja, we're talking about pacemaker and ICDs. This is care that should be available to everybody in Nigeria, and it's currently available here in Cardiocare. Thank you so much. If you have a question, just go to the Q&A box and write it. Okay, somebody asked about the left bundle pacing and conduction system pacing. Oh, I left out a slide on that. Okay, but I think we can briefly explain that. Elvis, can you try?
All right. So for left bundle area pacing, conduction system. So the idea is, the whole pacemaker history started with apical pacing in the right ventricle, and then that led to further research down the line. Some persons were having symptoms, developing heart failure symptoms, and all of that. Because when you pace from the right ventricular apex in particular, you are like initiating desynchrony. Some persons are fine with it; they don't develop anything; they're okay all through their lifetime. But some other persons might. So they began to investigate further how best can we get this right. So conduction system pacing is trying to pace directly. Remember we told you that the heart has its own electrical system.
Yeah.
So it's that system now that we're trying to pace directly on, so that it will just go natural, to look as if it is natural. It's like bringing another wire into your house wire, and then you pass it somewhere into the wall, and then just tap it there. Who are tapping from their neighbor's house, and then to look as if everybody has lights.
Correct.
So in the same way, you are going straight to those conduction systems that will send the impulse down to the ventricle naturally.
Okay, so
don't get any.
What he's saying essentially, so look at this heart model we have here. If you look at the, let me try and show it. This new. So if you look at the heart model that we have here, normally inside the heart there are already wires inside the heart, and those wires essentially, which are conduction system, they transmit impulse very fast and they transmit very well, so that they all work very fast. However, when we put a pacemaker, we normally are bringing an external wire, but we are connecting it anywhere inside the muscle and allowing it to spread through the muscle. So it now spreads through the muscle and it works very well. However, in some people it does not do as well, and down the line can cause them some heart failure. So conduction system pacing, which by the grace of God, Cardiocare pioneered in West Africa, we are the first to do it, and the only ones doing it in Nigeria and West Africa. We are able to locate the intrinsic wires that are passing through the heart and then connect directly to them. That way, when the pacemaker is sending its impulse, the body cannot tell the difference between that and the normal impulse, and the heart works normally as if it is passing through the normal system. That's essentially what the conduction system pacing. Abhishek, that's an Indian name. That's essentially what the conduction system pacing is. Now, the conduction system pacing is divided often into two: his bundle pacing and left bundle area pacing. His bundle pacing was done initially, but realized that a lot of times used to fail down the line, and it's not, even though it should be better. So when we started doing left bundle back area pacing, we found out that it's more durable. The left bundle is wider, so it is easier to do. Unlike the his bundle, which is very narrow, which I try to get, and it then lasts very long. So we've been able to do left bundle area pacing, which has been, very good for those patients. Okay, if you have any other questions, just put in the chat box. We will continue. Now we want to go into how is it done? How do we how do we put in pacemaker? So Elvis, we may use some people here, but just follow me. Follow me. I'm a good teacher. I think so. I think so. All right. So just follow me. After this, even if you cannot put a pacemaker, when they are doing the procedure, you'll be able to follow very well. For those of you that are around town and are interested in interventional, especially cardiologists, pop in, but you need to hear this lecture again and again. And a reminder, after the lecture, you get a link so that you can watch it on our YouTube page and on our pages. So fine. So let's go. Let's see how we can simplify it. So first, step one, evaluate the patient. Very simple, right? ECG, echo, stress in some instances. So patients coming in with slow heart. Remember why we say we need stress? Anybody remember why we say we need stress? Why we may need stress? Anybody remembers? Okay, great. We could need it anytime we're trying to test for chronotropic incompetence. When we think that the heart rate is slow, but more important is not arising to the needs that the body needs. Then you can do 24-hour Holter monitor. Sometimes you can catch intermittent heart blocks. Then you need to look for reversible causes, anything that you could treat. Otherwise, some things you give thyroid drugs, if it's hypothyroid, and you don't need a pacemaker. So after evaluation, you need to ask yourself 3 questions, not 2. Is the device really needed? Which device is needed? And then is the patient prepared for the device? So you are trying to prepare the patient for the procedure. You are trying to say which device is needed and whether the device is needed at all. So when a patient is referred to Cardiocare, what we normally do is the first thing we do, evaluate there will be a need for a device, which device is needed. So sometimes someone can refer for a pacemaker. And when we look at that patient, he might need a CRT pacemaker. Why would we need a CRT pacemaker instead of pacemaker? If the person has heart failure and also needs a pacemaker, you don't put just a normal pacemaker. You need to put a CRT pacemaker. And the reason is simple. You already explained it. We don't want to worsen the synchrony between it. But when you now start pressing the right will now start pumping faster than the left, and there will be synchrony. So you need to make sure that in patient with heart failure, you need to synchronize. So you need a CRTP. So if you send patient for a pacemaker, we will see evaluate. Patient has heart failure, we will need a CRTP instead of just a pacemaker. And then the other things we look at. So number 2, step 2, Elvis, what do you do in your procedure planning?
So in procedure planning, this is what we plan before procedure. So we want them to surprise. So firstly, you will have to know what the indication is, go through all the investigation, so you know what to anticipate.
Yeah.
And then you discuss with patient and family, consent is given, informed consent is given. And then we check the skin for infection, because the skin is infected, likely to transmit into the pocket while we're walking around.
Exactly.
That means that we're just looking up one for another.
You are just wasting time, because that device you have to treat away because you get infected.
Yeah. So then all of that needs to be checked. Then if the patient is on blood thinners or otherwise known as anticoagulation, if necessary, we'll have to stop. Of course, we'll have to stop, most cases. And then we'll also stop antiplatelets. If patients antiplatelet, we'll have to stop, and then give maybe a day or 2, to come for the implant. Then the team of course, everybody has to be formed, and then supplies have to be devices, what we need. But by the time we've gone through all of this, we don't care. All right, we need a pacemaker, a dual chamber pacemaker, of course. So that means we need an atrial lead, a ventricular lead, and then some other accessories that helps us.
The worst thing that can happen is that you put somebody, you're gotten there, and you don't have all your accessories. That could be terrible.
Yeah.
Okay, so, but that never happens. You make sure that you do all of that. You have the device, you have your leads, you have your stylus, you have your pacing system analyzer, you have your whole team ready, antibiotics, all of that. Okay, the other thing that is missing. Yeah.
Everything, the programmer is there.
So I will advise you, if you are in a center that is doing it, to have a checklist. Checklist, make sure that you don't forget anything. So now, this is the cath lab. Cath lab is preferred, although for just a pacemaker, you can manage the CR. However, when you are doing high power devices like cardiac resuscitation therapy, a CR will not suffice. A CR will not suffice. It will put patient A at risk. Okay, you can manage it, but I do not advise it. So typically use a cath lab. This is our cath lab, picture of our cath lab, and then we get the surgical tray, we prepare, we drip clean. I'll talk about cleaning and draping and all the local anesthetics that we typically use. Okay, so occasionally we normally do drug conscious sedation. A lot of times we don't do it often, don't always do it. The patients are a little bit sick, don't want to add to that sickness, and then the need for anesthesia and so many other things. But in other places, typically we give midazolam and fentanyl. Sometimes we do it, but not all the time. So we normally select patients that we use because typically patients that are here are high risk. Now, this is very important. You must not forget 99% asepsis infection control is not acceptable. No, we tried. No, it must be 100%. No room for error. We absolutely cannot afford to have any infection in pockets, in anywhere. And you know what happens if you have an infection? If you ever have an infection, that whole device has to come out. Everything it needs has to come out and it has to be thrown away. So very important, you cannot compromise on the procedures, on the hand washing, on the gloving, gowning, on the amount of people in the room, on the air quality, on the quality of the cath lab, on the quality of the flooring. Everything must be perfect. Perfect. If you have a list like normally have many patients, we typically like to take our devices first so that we make sure that the cath lab is at the, at the shiniest point. That is very, very, must be 100%. Yeah, so now I'm going to skin preparation. So skin preparation is very meticulous. Before the patient enters the theater, you have to first tell them, no cream, no lotion. We find that our patients are normally very, 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 not very clean, let me say that way. So typically on the wall, you should have some cleaning in the wall, you should have some cleaning in there. You should tell them from home they should have a bath properly. Wash that area, wash the armpits. Okay, we don't want if there's a lot of hair on this thing, it will better to be it will be shaved. Now we don't want razors to shave, very important, because there will be micro abrasions if you are shaving with a razor, and those micro abrasions could increase infection. So if you have to shave, just a clipper, otherwise just leave it as it is. Okay, if it's not too bad. So now we now take all of that, remove any earrings, first cleaning. Sometimes we don't have a full bath in the hospital before they come to me. It's now in the theater, and now lie down, mark the area, and then we clean again. Okay, how do we clean? We typically use chlorhexidine alcohol or povidone. Now, chlorhexidine is typically the one that is preferred. Use it, and you can go ahead straight away. If you are using povidone, also very good. For us, we typically start with Savlon first, spirit, clean the area thoroughly, and we are sure that the skin is well prepared. Then we go to povidone. If you are using povidone, however, the standard is for you to do twice. You clean first and allow it to air dry. Then you clean the second time and allow it to air dry before you go on to do whatever you are doing. That's the standard. However, using chlorhexidine, you can do once. Air drying is preferred. Do not blot. Allow it to air dry on the skin. So don't say, oh, let's just dry the place and let's start. No. Okay. And it's also important when you are after drying that the place is, especially if you're going to use dietary, so you don't go and cause any issues. As a standard, antibiotics are also given. Normally just before the procedure. We want the peak time of the antibiotic to be at the time you are more or less creating the pockets. Okay, so povidone, pre-surgical swabs are used. Of course, for patients, you need to make special in this consideration. Diabetic patients, obese patients, you need to have you need to take care of all the skin folds, otherwise you could have an infection. Okay, and sometimes you need to change the site completely. If there's some skin infection, you need to go to the other side, you need to make some special adjustments. And then if you have patient has known methicillin resistance and cause aureus, that's a very difficult infection to treat. You have to do a decolonization protocol first. Okay, fine. So just to point out,
the cleaning we've been talking so far is before draping the patient.
Yes, thank you. Thank you. So all of this cleaning, you cannot put your drip on an unclean place. You have cleaned thoroughly before you now bring the drip. Then you also drape the machine. because you don't want your hand to mistakenly. Remember, we said like 9% not accepted. So let me show you a small video of how the procedure is carried out. Essentially, the patient is monitored. We give local anesthetic to the area, numb the area very well. Some people break pocket first before access, then access before pocket. Either way is correct. Then we get the auxiliary. Normally, the auxiliary we hardly use subclavian or extra thoracic subclavian, and then we take our lead straight into the heart, just like you have seen in this video. When the lead goes straight into the heart, we are satisfied with. We test it. We screw it into the muscle. We test it very well before we put it inside the battery. After we have tested it inside the battery, then inside the pocket we have created, and then just wrap it up. So that's essentially how both pacemaker and ICD are done, including CRTs. The only difference in CRT is that there are multiple leads, 3 leads. The pacemaker is dual chamber, 2 leads. ICD, or if a single lead, 1 lead. Just like definition, just one. Very relatively simple procedure. So, Elvis, venous access. We need to go to venous access.
Yes. In some cases, yeah, actually we need venous access for both arms. Typically, since we use most persons are right-handed,
Yeah.
not to say that if you're left-handed, most persons are right-handed. So the dominant side, we use the non-dominant side, generally preferred. So we usually use the left side. So if typically we need an IV access on that left side, so that we can do a venogram to show us the direction of the vein, how the area is, and the tributaries and all. And also we might also need for the left or the right hand for medications, just so that we don't have influx around, because we're standing on the left side of the patient by this time.
Yeah.
You don't want people coming in, nurses coming in to give medication, disrupting the sterile area. They can go and go on the other side, even if there is an extension. They're not close to it.
So you need good IV access on both arms. One for the venogram on the same side, and one for any other resuscitation, IV drugs we need to give during the procedure. Okay, but then there's also venous access for getting the venous for the leads that we showed in the video, to get the leads, and then that's what it's. If you're just joining us, only from Cardiocare Hospital, explaining pacemakers, ICDs, CRTs, how we implant it. That is Cardiocare. That's the picture of Cardiocare here in Abuja, world-class center for cardiovascular medicine and surgery in Nigeria. So I'll just talk through the venous process very quickly. I'll not give too much stuff so that I don't confuse people. So the first thing is that the venous sources are 3. Extrajugular is there, but not really. 3: cephalic, subclavian, and axillary. Cephalic vein used to be the main one before, but now it's no longer being used very rarely. And the problem is that it takes a long time. You need to do a cut down, find the vein, and do that. Still good, low complication rates. Subclavian puncture very fast, very widely used till now. However, it has the higher risk of pneumothorax, which you don't want. Absolutely. I've never had pneumothorax by the grace of God, and God's grace to never happen. But axillary is the one that is normally used the most. And the reason is that it is extrathoracic, more extrathoracic, and you have fewer lead crush, you have less risk of complications. But the problem is that it requires some technique. So that is the predominant mode of puncture here in Cardiocare for several devices, hundreds of devices. We normally use the axillary, and very rarely the extrathoracic subclavian. So very important to know how it is. And you see that for the people if you're using cephalic veins, you need a lot of surgical skill. But pneumothorax is the least is there. But you see the one that we normally use here in Cardiocare, this is a paper published by Rajapan in Hearts, 2009. You see that the extrathoracic subclavian and axillary has similarly low risk of pneumothorax and subclavian clot. So typically, that is the one that we use more. Can pass multiple leads. Extraction is also easy, and then very, very good access. All right. So cephalic vein, I'll not talk too much about. Like I said, it's something that people have to do, but involves cut down. You do a cut down, you find vein, and you expose it. Subclavian also, people still do it. It's about using landmarks under fluoroscopy and then going under the skin. But the risk of pneumothorax is there. As you are passing that thing there, you go into the lungs. That will be important. But if you are used to it, that is also good. But it's being shied away from. And the risk of crush leads. So the leads will crush while it's passing there. And that will mean that 1 or 2 years' time, you may have to come and extract. That can be disaster for the patient. Okay, and then the subclavian method. The subclavian method is here, of course. Axillary. Axillary is here, of course. And the axillary, sorry, we had the Nigerian thing. So in the axillary vein puncture, which I showed you, typically you identify the first or second rib. Now there are different ways to use this, to do this procedure. But very important, and this will be the trick that I will show you for those that are playing now. You can see the first rib. Let me see. Let me point out. You can see one way which we used to say is okay, where the first rib meets the clavicle will be a good point, correct? But sometimes, especially in the elderly, this may not follow through. So one of the things you want to look at is where the first rib or the second rib becomes a little bit vertical, like here. You see, it comes like this and it becomes vertical here, comes like this and becomes vertical. That is the area you are aiming for. You want to make sure that your needle does not cross that rib. That rib helps you to protect. If you cross that rib, you can enter the lungs. So you go there. So at that point in time, the risk of pneumothorax is there. But once you are over the rib, you can never have it. You can't pass through the rib. So you don't play over the rib, and then you go straight there. At the point where the rib becomes horizontal, and you can see that. Now, you could add another thing. You could turn your cath lab to 40 degrees corner. That is, make the eye go towards the foot of the patient, 40 degrees. That will help determine the depth so that you can be sure that once you are sure that you are over here, you can go 40 degrees and be sure that you are not crossing the rib cage. So if you want to know the depth, I use the corner view to do that. I don't normally need that most of the time. This is normally, but a lot of times you combine both of them when you are using, especially in very difficult cases. Okay. You can see that the vein outline here. It's not always so. This is when a venogram has been done. So what is venogram? Elvis, can you explain the venogram?
So a venogram is it's an image that also to see the anatomy of the vein. That's, as we can see on the picture, we can see the subclavian vein, how it passes through between the first rib and the clavicle and then down to the SVC. So that way we know where vein is and where we want to target to plant eye and leads from. So venous access is actually important because we're actually using the right side for most of our devices, in fact for all devices.
Yeah.
But however we end up putting, if we're doing the CRT, it's still from the right side, we go to the right drum and then we let the coronary sinus ostium, and then from there also you go to the left. So it's usually a right side thing. And that's where the vein is empty into. So we trap to the right hand through the vein. So
all right. So that essentially is what we do. And when people are just starting, one of the things you should do is to do a venogram regularly so that you can do it. But a lot of times we don't do that all the time. Do it in I'll give you instances when you do it. So use the PA and order to help you to land more like I explained. And your needle goes there at that point in. So you look at it, first rib is coming like this, axillary vein from here, subclavian vein from here. And you have the cephalic vein, we're not using that, we're using here. So just here, where the axillary vein is about to become the subclavian vein, and the medial border of the first rib, the axillary vein becomes subclavian vein. So you don't want your needle to cross there. If it crosses there, then you're inside this space, and that space can take you into the lung space. So we don't want that. So very important, and that this extra distance helps to minimize crush risk. Now, sometimes you could use ultrasound to get it, and this is very important. And you can use this even when you are doing the central venous line. So if you do the ultrasound, you can see the fat layer, you can see the pleura, you can see the lung, and you can see the vein. Now, very important if you're using ultrasound, after you have identified it like this, turn your probe 90 degrees so that you can see you can see the needle all the way through as it's passing through. You can see the distance between here and the lung. It's not much. It's very important for using ultrasound. So you can see how I've turned it. So in this case, this is axillary action. But when you turn it this way, you can see your needle as it's going all the way like this way. You can see the needle here as it's going all the way. So once it enters, you can see it, and you don't have to go through and through, which is why you need to turn it a little bit. This way. You can have it and try and see your needle as you are going all the way. So if you look at this, for example, they have already made a pocket. That's why you have this pocket. This is the needle going in here, the needle going in there over the first strip, and as it gets this thing, how will you know? You are pulling back, just like you're taking a venom puncture. Pull back, then you cannot introduce your wire. That's the wire going in there. Very important to note, the wire is bending, no problem, continue. It's very important to note, you want that wire to cross the spine. That tells you that you know the an action. You want it to go below the heart border. Very important, because if you enter the aorta, you likely will go and hit the aortic cost. You want to go below the diaphragm. You are sure that okay, it will not enter the artery. If you enter the artery too, you will see it coming out with a lot of pressure. It's very important in that regard. But please and please watch out. Watch out. If you enter the artery, it's not a problem. Just stop, apply pressure, and do. Now, if you enter the artery and you don't recognize it, that's when you can have a problem. So if you ever hear somebody, something went wrong, that's like maybe what happened. Luckily, we never had such a case. So once you move and you realize you are there, just move your needle, put pressure, everything will pass. However, if you pass your sheet in and you dilate it, that is when you have entered. It's only God that can save you and the patients. Fine. So we go through that and then we avoid sharp angles. And if you follow the procedure I talked about, you will never have a pneumothorax. Okay? And then when must we do a venogram? Elvis, these are some. Can you talk us through when sometimes we must do a venogram, or it's very advisable to do venogram?
So in some cases where patient already have a device, maybe a virtual device, and you want to upgrade it to a CRT, or the patient has a lead function, and then such that it requires the lead to be replaced, you want to put in a new lead so that the device can work properly.
Yeah.
You need to do a venogram because some time when you have this leads in the heart, in the veins, there could be some anastomosis that would form around it. So then also there could be some narrowing, form around it, and that could lead to venous occlusion. So you want to be able to be, but if you just go blindly, you might not be able to tell that
the vein is blocked.
So when you do the venogram, you can tell that this vein is still patent. I have room as well to put in another lead, and it
so whenever there is a existing mandate, I stand up really. If you do something else and get away with it, well, thank God for you. But if you don't get away with it and something goes wrong, you will need to explain yourself. So very important.
And also for people who are grossly obese, because due to their obese nature, the anatomy might be a little bit different. You might need to go in deeper and all of that. So it's just safe to avoid issues of perforating the lung. You just go straight to do a venogram. You know where your veins are, and you go straight for it. Also, people with risk of pneumothorax, bleeding, or high bleeding, and people like with COPD. People are elderly, very elderly, their body's frail.
You don't want
to go to
any mistake. You are with cost problem.
You don't want to go because people want also anticoagulant. You want to go once so that you don't mistakenly hit the artery and then you start compressing and be fine. And known to you, it's still bruising because of the anticoagulant or antiplatelet. And so generally in this class of people, it's important that you do a venogram. People where we suspect venous or anatomic deformity. So, for instance, maybe breast surgery, fracture, or people who had some surgery, plastic surgery
around that area.
So you want to do know the cost that the pain is still taking.
Okay, so let's move on. We're not create a pocket. So what do we do to create a pocket? We just want to create a space that can carry a device. So just a small pocket enough to carry a device. Typically, you want the pocket to be in front of the muscle, but sometimes you could do it superficial. Sometimes you can do it behind the muscle, depending on how the person's skin is. But you really don't want anything that causes any erosion. So pockets weight typically we take an incision parallel to the clavicle. Okay, so people do the other forms of incision, do a curved incision. I know one of my teachers from Edinburgh, he does incision straight across like this. Very fine. Well, I'm not used to that, but I put it in my belt. Maybe one day I make it. Okay, so some people do that, and people that train in those older days typically we do this curved incision or this other incision so that they can either do a cut down for cephalic or go femoral, axillary, depending whatever they want to use. That's why they do that. Normally these days, typically do a straight pocket, and this is the ideal direction. Don't want you to have any problem down the line. So you can see, take the knife. You want to take one smooth incision, sharp, and then you use your finger to create a pocket. So once you go down, you meet the fascia. Fascia is like that white that covers it. Once you get there, you are over the muscle, right fascia. If the person is very slim, like an old lady, you might have to go some muscular. Cautious, it will be more painful. Number one, and number two, bleeding is likely to be higher. So you need to do that. We create the pocket, we flush out the pocket, we say like a lot of times we gotta put a temporary gauze that helps maintain the hemostasis, keep the place clean before we put the device. Okay. Then of course we check the sheet. So what is the sheet? So if you look at this our video now, if you look at this our video, number one, and make sure that this is your wire. Remember you got our access and we pass it by. Make sure that this wire is on the floor, that it's not on the edge of the wound. You want to be on the absolute floor of the pocket. Okay, that's what we are doing here. Make it on the absolute floor of the pocket. Don't overload this. Otherwise, to be too close, you need to come out too close to the skin and you have a risk of erosion. Very, very terrible thing that should happen to anybody. So you have a risk of erosion. So you don't want to overlook that. We'll take our sheet and then we'll take the sheet. So you can see how we clip the wire there. This is a borrowed image from an Indian hospital. Okay, so make a slight curve on it so that it comes very neatly across the curve into the right direction. We don't want it to hook in the subclavian or anywhere else. So we pass the wire over it. You can see that. Always make sure your wire comes out first before pushing. Otherwise, you can push the whole because your wire in, and you create a different problem. So your wire is in, and then you put that. Now, the golden rule of interventions, interventional cardiology, never introduce something to the body without visualizing. So you're looking at it as a visualizing. You don't want to create any problem, and you do it gently. If you feel anything stopping it, stop. Don't push hard. Okay? And then that central generator follows that. The sheet outside is a peel away sheet, so it makes it very easy to do. So to look at that, we pass it over. This is a safe sheet. Put about a safe sheet that has a valve, block and not flow back. So put it over. Then the sheet is inside, the wire is still there. Then we can take out the wire and take the lead. This is the lead we talked about. Remember the lead? Let me show you the lead again. Okay. Take the lead and then we pass it through the safe sheet into the heart, and then we now manipulate it to clip muscle. Once we have clipped the muscle and tested it, then we split the sheet. You can see how we held it down and we tear the sheet away. So we don't have to pull the sheet over the distance. Once we just tear the sheet, it's like an envelope. And then, so for those just joining us, we are working from Cardiocare, National Center of Excellence in Cardiovascular Care. We've been doing this for over 5-6 years now. And very successful cases, over 1,500, over 2,000 cases. So I'll continue now. Elvis, should we go to this more technical things? What's happening? Anode cathode. No, let's shift. It's too technical. So let's talk about this. Elvis, let's talk about this.
So this is a picture of what the leads look like. And there are two types of leads there actually. One is the one we're talking now, that's called the time lead, the passive lead. It has times that you can see it's period, those extensions, those are tines. So it's a passive lead in the sense that it does not, it's not actively screwed into the heart, just like the other one that you can see active fixation. It has a screw.
Yeah.
That screw is screwed into the
Can we screw? It's like a spring. It will screw into the heart muscle, so into the myocardium. Unlike this one that does not have anything.
So the passive lead will just be directly having contact with the myocardium, and because the right ventricle and even the atrium has fenestration, in
The trabeculation.
in the appendage or down towards the apex. So by the time these lines cross in through those trabeculations, it will just hook somewhere, but it will be having direct contact with the myocardium. That's how that one works. But for the active one, anyway, you can always screw, and then you don't have, it's actually better than the passive leads for the battery, and then for in terms of stability, it's more stable.
Yeah.
So this is what we typically use nowadays,
Yeah.
the active fixation.
I hardly find this at all.
So those ones are just the difference.
Okay, so to pass the lead, we normally take some stylets, we shape it and put it in. That allows us to be able to shape the lead. When we are finished putting the screwing the lead, we connect it to the lead. We first test the lead that is doing very well. You must test the lead. You must test the lead. You must test the lead. I know some people just collect the lead and maybe because they don't have programmers, the standard you must test the make sure that you have good parameters before you now connect it to the device. Connect the device and then you screw it onto the device like that. Now, if you look at this case where we are seeing lead insertion, this point where pass the lead, this is where the sheet has ended. At this point, if you are not careful, you need to pull back the sheet a little bit sometimes and be careful. Don't push with too much force. This is a critical border. If you push with too much force, you could tear that SVC. You could tear that SVC. So people that are very rough operators sometimes have this kind of problem. Once you are getting here, you will need to shift back. Or if you have a long sheet that continues all the way down, then you have this problem. But otherwise, you may need to shift it back a little bit before you put it in, and then rotate the lead. Don't push with too much force. Sometimes you might even pull out the stylus a little bit, so the goes here, so that it's a little bit very soft and does not go with so much force. Very important when you are passing in the lead. And then for the apex, this is from this textbook. Typically, as you pass the lead, try and cross the tricuspid valve. So that's why we have to shape it. There are several ways we shape it. Go to the normally we take the RVO to the right ventricular outflow tract. Then you can pull down and then push it onto either you get anywhere on the septum. Okay, so that is typically how we do. So you see, typically in this AP view, that is anterior posterior view, we can see this around where the atrium is. This is the RV, and then it passes through. In this paper in Hearts in 2009, it talked about different ways. This way is very common. If you're having problem passing your lead through the tricuspid valve, as you come here, you pull back your stylet, it will now collapse. You now push the collapse thing in, and then push your stylet back in, and then eventually it's shooting out. Or it may just cross directly, and occasionally it can cross directly and go to where you are going. Otherwise, you go to the LVOT, bring it down. As it's falling down, you now push it forward. So this is very, very simple placing of the leads. So if you look at this one now, this is RAO, meaning that we've turned the cath lab towards the right of the patient. Okay. In the RAO, we can see that it's at the apex, and when we turn on the LAO, we can see pointing towards the spine. However, when it's pointing more towards the septum, we can see it in the RAO view. You can see how it is pointing up in this, and then LAO, still the spine, but it's pointing at an incline. That is a more septal placing. Now, we don't want to go to the true apex. Even this apex we're talking about is the apical septum. We don't want to go to the true apex because if you look at this, and if you've been for any of those trainings where they have animal hearts, the apex is very thin. If you turn it pretty much to scoop food. So the true apex can be thin sometimes. So we want to go to the apical septum, not the true apex. Have you add anything? Okay, fine. So if you look at this, the RAO10, this area we can accept some technical septum, but more not we are aiming for somewhere. Sometimes some people aim for high septal, and sometimes in patients with heart failure, sometimes from myocardial infarction or whatever, a lot of this wall may be dead. So you might be looking for a place, a suitable place to be able to put your lead. Now, when you put on LAO 40, you need to differentiate that you are not, your lead is not facing here. If your lead is facing here, but you are facing the free wall, that means that you are facing outward like this. Any small thing, you have box to the heart, the patient will not forgive you because it may not be alive. So you want to make sure that sometimes you need to come for LAO 40, use this to confirm to yourself. If it is towards the middle, you are towards the septum. If it is towards this other side, you are facing the free wall. So you start it and you check. After that, normally we switch the sleeve of the suture. We don't want the things to move, so we suture it and suture them together. Right picture is similar, very, very simple in that regard, and then we test. Now, Elvis, this is your own. But we have to finish in the next 10 minutes, so we need to be fast in talking about lead testing before final.
All right. So what we want to check, like Iseko mentioned, if once you plan the lead, you screw it in. You want to check that. You also mentioned that some areas are scanned. So you want to check that where the lead is implanted. You know, by just looking at the fluoroscopy is 2D. You cannot tell where it's scanned and where it's not scanned. You want to check that where the lead is implanted. Parameters are fine. These are the ideal parameters. Atrium, you want to be sure that you're getting P wave that is greater than 1.5 millivolts for the ventricle greater than 5. And then generally for the capture threshold, we want something that is less than 1. Sometimes we might accept 1, which because we know most times it likely decline, but not something above 1.
Yeah.
So impedance within 300 and 1,005, preferably less than 1,000. That's great. And then stimulation testing, we also check to see the how it changes on the ECG.
So we'll start pacing, and then we'll see whether the ECG is showing that it's capturing, and then there's no muscle twitching as well.
Yes. So we do this using the cable.
Yeah, the
pacing cable. You can see on the picture there.
Yeah, here. So we connect after we have implanted the lead. Now we connect the cable to the end of the lead. So if you look at this as being the end of the lead, we take this crocodile mouth and then we connect that. Okay, so once we connect that, black to the back and red to the ring, then we connect that to our interrogation device. Our pacing part goes to the pacing. Correct. The pacing analyzer.
So that's where we get to see the values of the P wave, the values of the PRS.
It's very important to check this. You don't want to connect to the pacemaker and before you get 1 year down, the pacemaker is dead because you did not get a good place. So you need to test. You must test it on the computer and you're sure it's good before you connect the pacemaker. No rushing to do anything.
Yeah, so we do our checks and then we pace to find the capture. So we decrementally pace the heart from maybe, let's say we start from 3.0, we keep going down to maybe 1, and then 1.5, 0.8, 0.6, like that, up to where the device the lead no longer stimulates the heart. So at that point, we can tell we have a good capture threshold, and then, this is fine. We can then proceed. Impedance is also within range. The P waves, the values, PRs are also within range. There's also a good current of injury, and then on the fluoroscopy, the lead is stable. There's a way we test for stability.
We don't want to come and dislodge. Sometimes, if you don't check all of these things very well, and sometimes maybe just like that, the lead is not well anchored into the heart muscle wall. So if it's not well anchored, and then it starts beating when you finish, you think you have had a good case. The next day you come and check, and the lead has moved because it was not stable enough, and you have to go back again because otherwise you are in trouble.
That increases the risk of
infection,
which we don't want. Just a simple check would have saved all of that.
Okay.
So that's the machine. That's for metronomic devices. That's the machine that we typically would use to do all of these checks. So one also observe for native reading. because that's where we sense, that's what the device wants to sense. So, and if it's not seeing well, it cannot be able. So if it needs to see well, and for it to see well, it has to reach that value. And then the same thing too, once we are done with the sensing, there's sensing and there's pacing. Remember the VVI.
Yeah.
So the pacing part is all about the back capture, because we want it to be able to stimulate the heart. If it cannot achieve that with little as less than 1 volts, then we have not really gotten a good place. So we want to ensure that we can deliver pacing
with a very low
voltage.
If I use a high voltage to deliver pacing, the battery will run down. Yeah.
So we also check the impedance. The analyzer is able to tell us what the impedance is between the lead, it will just sum up the impedance and then give us a value. So based on that, we can tell that, oh, the impedance is too high. The impedance is too high. It means that it will take a lot of current for that lead to pace the heart, and that will also affect the battery life. If it's too low, that's not good either, because the current will just come out very fast. And then low impedance, so low impedance will be less than 200, high impedance is greater than 2000. So we pace at high amplitude and observe for abdominal twitching, and that's because sometimes, if for instance, we know the threshold is going to rise for a period of time.
Yeah.
So, and then also, if for instance there is a micro dislodgement in while the patient is going like, sometimes the device might tend to upregulate itself to go higher. So if it does that, and then maybe, so we check first to be sure that if we pace at a high voltage, the diaphragm will not twitch, the abdomen will not twitch, like a hiccup. Like none of that happens. So that means if the device has, for any reason, we just need to go higher just to ensure capture, there won't be abdominal twitching, because that can be very disturbing. Imagine you just at every heartbeat, every heartbeat, you don't want to, it's very, very disturbing. So we do all of that, and then the lead is then sutured. So if you look close to the white spot here, you can see something dark. So that's the sleeve of the lead. And then it is sutured just to be anchored properly. It's sutured to the muscle, anchored properly, so that it will not it will move. And then we also give a slack to the lead. All of this is just to reduce the risk of dislodgement.
Okay, very important. Don't underscrew, don't overscrew. Be careful, follow the leads. This just to remind you from Cardiocare, this is not an instructional video or teaching that you can go and start like that. This is so you can have an idea of the process and everything. You cannot watch this alone and go, and this is just an instructional educational content. You cannot, based on this, go and carry a patient there. No, that's wrong. Please do not try this at home. There's a lot of extra training that is needed. You need to be in the cath lab and watch many, see many things. And there are so many things that are not captured in this. So this is not enough for you to start fixing. Okay, then we close the whole pocket after we have put the device. Do a chest X-ray to be sure that everything is in place. Load the pneumothorax. And then I showed you this case that happened. And just again, this is how the device is normally put in. Pockets, anticoagulation, skin preparation, pre-operation, measure the correct patient, make sure they did it, get a good venous access, get the access into the muscle, connect to the device, put the device, test the lead very well. Then check for stability of the lead, suture the lead very well, connect to the device, and then we'll now put the device, so take the wire and connect it to the device. Then we test now that the device is together, and then we now put it in, and then of course immediately we check the device thereafter. Okay, so and this is what it looks like thereafter. So we had the patient also electrical storm, lots of shocks coming on and on and on again. And you can see CVT, ventricular tachycardia, and then the ICD has treated and it has come back to normal. So give her a small shock, and see the heart rate 196, and then after it shocks, give the small shock, the heart rate comes back down and keeps on coming back down, and she's back to normal. So this is this is just a demonstration of it. This is a real patient that was here in the Cardiocare. It's about 2 years ago. And of course, some of our bundle area placing were breakthrough hospital in Nigeria and West Africa to be the first to pioneer bundle branch area placing in Nigeria and West Africa. And this the first case was in 24 years ago. Very nice, beautiful. This was his PCG pre-op, and very important. You can see the name, see how narrow QRS complex is. See how narrow the QRS complex is. Now, after we have started placing, you can see it remains narrow. This is why we really like left bundle branch area placing, especially for this person that is young, 24. He's going to use a pacemaker for the rest of his life. So you want to get the best possible pacing for him so that he does not develop heart failure. Okay, and of course, this is a CRT. You can combine this is CRT. So you see the CRT. Can we see how wide this QRS is in V1? Can we see this V1 here? So in this case now, there's desynchrony or in this area, and now you can see that it's narrowed down significantly. This narrowing will typically translate to better care, better symptoms, and all. Then we had this 52-year-old man who unexplained the correct syncopal attack. One of our senior colleagues did this case. Just fainting. Did 24-hour ICD, nothing related to symptoms. So a loop recorder, while we talk about the loop recorder, we didn't go through that one. It's just like a pacemaker, like this one is only sensitive. Okay, and the loop recorder is very simple. We put it in the clinic, sterile procedure, put it with the insertion device, put it under the skin here, and then you close it. Very simple. And then following the interrogation of the loop recorder, we know that it's having intermittent complete heart block. Put a pacemaker, and that was the end of the sudden collapse. Of course, again, I'm just reminding that this from Cardiocare. Thank you for joining us. We will take any questions. We'll take any questions. This is our cath lab. You can reach us. You can reach us through the email, through the phone number, and through by coming visit. If you happen to be around Abuja, pop in. Let us say hi and let us show you some of the magic that's happening here in Nigeria for our patients. God bless you. All right, so let's see if we have any questions that we need to answer. I think we have done quite a thorough review. Some people have run away, or the team was getting too hot. Some people have run away. Okay, so are there any questions? If you have any questions, you have answered that question. You have answered that. If you have any questions, just use the chat box. I can see there are some hands raised. Isaiah, did you mean to raise your hand? Or that was... I'm going to lower your hand. So if you mean to raise your hand, just raise your hand again. Okay. Evans has raised his hand. Nobody raised. Okay, fine. You need to raise your hand to talk. Let us know. Otherwise, just put your question in the chat box, and then we'll answer your questions here. If you look at the chat in the Q&A box, Q&A, you will see a link to join the WhatsApp group so that you can get access to upcoming webinars. You can get access to information and to how to get your slides and everything. You can use that link, and 1.5 CME point to be given to you. Thank you all. Thank you, Umar, for thanking us. We're grateful. Thanks. Thank you all for joining us. Huh? Yeah, the contacts are here. The contacts are, if you want to click this link, this WhatsApp link, all the contacts are there. And then you can also reply to the email that I'll be sent to you. So once again, thank you all for joining us. We're very grateful. With this, we've more or less come to the end. Thank you. And if you have any patients that need any of these procedures, not just this ones, coronary intervention for heart attacks, chest pain, cardiac evaluation, stroke, ICU, cardiac surgery, all of that. If you have your patients, you can send them over. We will take good care of them. And then we, of course, Nigeria will be better for it. God bless you all. Let's call it a day. Have a lovely weekend. If you are living around Apo Wumba, we'll have a health walk tomorrow, 7 a.m. We kick off around 8. Finally, for 7 a.m. Try and be there early. We'll do a brief health walk. Join us, let us join. Thank you so much. In testing, you did not mention the contraindications. Is that what CI? Is that what CI means? You did not mention what do you mean by CI? What do you mean by CI? You did not mention the CI. Oh, point of injury. Yes, okay, fine. He mentioned the corridor of injury. So corridor of injury is like, it's like, when somebody has myocardial infarction, the way they have an ST elevation. So when we test, we can see whether you have a good bite, corridor of injury. Yes, very important to check as well. Thank you so much, Kerele. Thank you very much. All right, let's have a lovely weekend. If you are in Abuja and around the local Guma, see you at Great Research Center for the health walk tomorrow. God bless you. Have a lovely day.